Hey everyone, welcome to The Explainer. Looking through the source material for medical boards, it becomes incredibly clear that Salmonella is an absolute high-stakes heavyweight. It literally combines foundational microbiology with some really high-risk clinical decisions. So let's strip away the fluff, review these notes, and lock down exactly what we need to know to crush those really tough clinical vignettes.
Okay, let's dive into this. Here is our 6-part battle plan. High-yield Salmonella basics, the typhoid timeline, the typhoid versus NTS showdown, diagnosing enteric fever, treatments and vaccines, and finally, exam traps. This structured approach is going to lock down those essential facts for exam day.
Section 1. High-yield Salmonella basics. Just a quick reminder here. We are kicking things off with those rapid-fire microbiology one-liners that examiners absolutely love to test. So at its core, Salmonella is a gram-negative, non-spore-forming, facultatively anaerobic bacillus. But here's your first really testable detail. Almost all Salmonella species are highly motile. Just think Salmonella swims. And that's thanks to those paratrichous flagella. But definitely notice the specific exception here. Salmonella gallinarum pylorem is the rare one that actually lacks this motility. Then when it comes to serotyping, you've got to recognize the O-somatic antigen, the H. flagella antigen, and this is a big one, the Vi-capsular antigen, which is exclusively found in Salmonella typhi and paratyphi C.
Now, what's really interesting about this slide is how examiners absolutely love testing exceptions. Take a look at the lactose fermentation. While almost all Salmonella are non-lactose fermenters, a tiny 1% are rare clinical isolates that actually do ferment lactose. But honestly, the H2S production, that's the real big one. Almost all Salmonella species produce H2S gas, which shows up as these black colonies on agar. The massive exception, S. typhi does not produce gas. Burn that into your memory, for sure.
It really helps to divide these into two distinct clinical groups. Satyphi and paratyphi. They are exclusively human reservoirs, no animal hosts at all, and they cause systemic enteric fever. Contrast that sharply with non-typhoidal Salmonella, or NTS. NTS hangs out in multiple animal and food reservoirs, like poultry, eggs, and reptiles, and it causes localized gastroenteritis and bacteremia. So just remember, humans versus animals, systemic versus localized. Moving right along to Section 2, the typhoid clinical timeline. We're shifting from basic micro to a little mini narrative here, tracking that classic 10 to 14-day incubation period straight into the infamous 4-week clinical course.
Imagine you're reading a question stem, right? If a patient presents in week 1, you're looking for an insidious fever, maybe some faint salmon-colored rose spots on the trunk, which actually only appear in about 30% of cases, and the Fagit sign. The Fagit sign is relative bradycardia, and you can remember it as fever and greatly expected tachycardia missing. Moving into weeks 2 and 3, the fever takes on this really classic step-ladder pattern, and you'll see splenomegaly and marked toxicity. But weeks 3 and 4, that is where things turn deadly. This is when intestinal hemorrhage and perforation can happen, basically due to necrosis of the pairs patches right at the ileocecal junction.
Okay, Section 3, typhoid versus NTS showdown. This is really the climax of our explainer, a direct showdown between our two main adversaries, so we can prevent some critical diagnostic errors. This breakdown gives you some really punchy contrasts. Look at the incubation. Typhoid takes a slow, sneaky 10 to 14 days, while NTS hits you fast, usually within 6 to 48 hours of eating that bad chicken. So the crucial point is right here under primary site. Notice the cellular response. Typhoid causes a systemic mononuclear infiltrate, basically hiding out in the macrophages of the reticuloendothelial system. NTS, on the other hand, triggers a localized intestinal polymorphonuclear infiltrate. Clinically, this means typhoid gives you that prolonged fever and rose spots with deadly week 3 complications, while NTS is your classic, completely miserable, but self-limited 3 to 7 day bout of vomiting and non-bloody diarrhea.
Up next, Section 4, diagnosing enteric fever. Let's pivot to an examiner's absolute favorite topic, identifying the definitive diagnostic tests.
80%. When I was reviewing these tests, this number kind of blew my mind. It represents the sensitivity of a bone marrow culture for diagnosing typhoid. Blood cultures, they only have a 40 to 60% sensitivity, mostly because the bacterial count in the blood is actually surprisingly low.
But bone marrow culture is the undisputed gold standard. And here's the absolute kicker for your exams. Its 80% sensitivity is not reduced even if the patient has been on prior antibiotics for up to 5 days. That's huge.
So beyond the bone marrow, what else are we working with? Well, stool cultures really only turn positive around week 3 in untreated folks. The duodenal string test is cool because it can catch it when blood and marrow miss it, and if you combine cultures, blood, marrow, and intestinal, you push that sensitivity over 90%. But take a look at those bottom 2 points. First, the Widal test. If you see this as an answer choice, it is almost certainly a trap. It has notoriously low sensitivity and specificity, so it's just not recommended. Finally, look at that blood panel clue, leukopenia with neutropenia. This happens in about 15 to 25% of cases, and it's a massive, highly unusual diagnostic clue for a bacterial infection, pointing heavily toward typhoid on a standardized test. All right, Section 5, Treatments and Vaccines. Let's transition smoothly into management. Keep in mind, geographic resistance patterns make treating these infections highly testable. For empirical treatment, ceftriaxone or oral azithromycin are really your go-to agents. And this brilliantly illustrates why you absolutely must read the geography in the question stem. You simply cannot blindly use fluoroquinolones empirically in endemic regions like India, Pakistan, or Bangladesh anymore, all because of widespread decreased susceptibility. Plus, if the vignette mentions a patient arriving from Pakistan, beware of extensively drug-resistant, or XDR-S typhi, that requires carbapenems or azithromycin. Now, for severe typhoid presenting with shock or obtundation, giving dexamethasone dramatically reduces mortality. It's a real lifesaver. And for the 2 to 5% who become chronic carriers, they need a full 4-week course of fluoroquinolones, or even surgery if they have gallstones holding onto the bacterial biofilm. Prevention is just as heavily tested. Let's walk through the 3 vaccines chronologically, based on the minimum age they can be given. Step 1 is the Ty21A. It's an oral, live attenuated vaccine that requires 4 doses, but you can only give it to kids 6 years and older. Step 2 is the VI-CPS, a parenteral capsular polysaccharide vaccine. Since it's a simple polysaccharide, it's T-cell independent, meaning it won't work in tiny infants, so the minimum age is 2 years. Finally, the real game changer, the typhoid conjugate vaccine, or TCV. Because it's conjugated, it is T-cell dependent. Just think, TCV targets T cells. This gives it a massive 79 and 95% efficacy, and crucially, it works in infants under 2 years old, making it the WHO recommended choice. Moving to our final part, Section 6, Exam Traps to Avoid. Listen up, because these are classic board traps specifically designed to trick you. Read this carefully. Antibiotics in NTS gastroenteritis are not recommended. If a healthy 25-year-old gets uncomplicated, non-bloody diarrhea after eating some undercooked poultry, do not give them antibiotics. Doing so is a massive trap because it actually prolongs the carriage of the bacteria, it increases the relapse rate, and honestly, it just risks adverse medication effects. It's a self-limiting disease. Just give them fluids and let it pass. But as you know, in medicine, there are always exceptions. Let's move to 2 and see how this builds. You only break that no antibiotic rule for NTS if the patient falls into a highly vulnerable group. We're talking about neonates, patients over 50 with atherosclerosis, the immunosuppressed, or those with severe localized infections. A premier, highly tested example of a localized infection is Salmonella osteomyelitis, which is heavily associated with sickle cell disease. Let's wrap up with a classic vignette. A sickle cell patient presents to the ED with severe bone pain and a week of fever. What is the organism? Boom, Salmonella osteomyelitis. If you can recognize that instantly, you are absolutely ready for test day. But, seeing all this leaves you wondering, with XDR typhi strains rising globally and spreading from places like Pakistan, how long until our empirical guidelines have to change completely once again? Thanks so much for joining me on this explainer. Keep up the great studying, and I'll catch you next time.